But the problem is that if you're going to do a lifestyle change, there's not enough time to address that in short visits. So if you have a 1-hour visit, you can address more things, but you will address way more than if you do 4 15-minute visits, or in my perception, 25 15-minute visits. So I just don't think that model of short visits ever works for discussing complex lifestyle change. It just doesn't work. So people say, well, it's hard to practice family medicine with 15-minute visits. And I basically, my contention is no, it's not possible. It's not at all hard. It's impossible.
Aase here with the Take Charge podcast with my co-host Dan Hinmon. And Dan, today we're blessed to have with us Dr. Dave Strobel, who's almost a lifelong friend of mine, and glad to be able to introduce him to our audience. So Dan, you want to take it away?
Sure. So let's start by saying, should we call you Dr. Dave or Dr. Strobel?
Dr. Dave is what I usually go by.
And that's how your patients know you? Awesome. That's really great. So please tell us a little bit about your life. Like, where were you born, high school, college experiences, family, anything you want to share with us about your background?
Well, nobody can say where they were born because they don't remember that. So it's always they have to trust the people who told them. But I kind of trust my parents. And they told me that I was born at the hospital at Maxwell Air Force Base in Montgomery, Alabama. My dad was an attorney with the Judge Advocate's office there, I guess. And so I spent the first 2 years of my life in Montgomery, Alabama. And then my dad moved and worked for a company that people would recognize called the Maytag Company. They used to make washing machines and stuff like that. And that was in Newton, Iowa. And I started school in Newton, Iowa in kindergarten and went to first grade there. And then in 1970, that tells you kind of how old I am. I was born in 1962. And I came to Austin, Minnesota when my dad left that position and came and worked for what was called then the George A. Hormel Company. And now it's called Hormel Foods, or Hormel Foods is what people pronounce it. So from 1970 until 19, I lived in Austin, Minnesota. And Austin is the international headquarters for the Hormel Company. I graduated from high school in 1981. He and I first met each other probably in 7th grade. I don't know, maybe it was something like that, or 8th grade. And that was middle school in those days. Now that's kind of been divided up. So it was 7th and 8th grade at that time. So it's probably about 1970.
Well, 50 years ago. So yeah, we've known each other for about 50 years.
About that.
We are old.
And so we met at that time. So we were high school classmates and graduated together. I am much older than he is, however.
He's a whole year older almost.
And then I went away to college at the University of Wisconsin, and then I went to medical school first at the University of Minnesota in Duluth, which is kind of a primary care emphasis school. Did the second 2 years of medical in Minneapolis area at the school there, and then did my residency in Sioux City, Iowa in family medicine. And then after that, under my wife's influence, actually moved back to Austin and started my medical practice with what was then the Austin Clinic, which was an independent medical practice in Austin, Minnesota. Went right back to my hometown. That was 1992.
Well, and tell us about your philosophy of care. As you meet with patients, what's important to you?
Sure. Well, one of the things is that I try as much as possible to tell patients that doctors aren't fixers, we're advisors. And so it's really the patient's job to take interest in their own health care, and my job is to provide information. So, I don't decide what to do. I tell people information, and then they decide what to do, basically. Now, that's not completely true. Somebody can't decide to take abusable medicines and just have me prescribe them, things like that. But nonetheless, I as much as possible, tell patients, you're in charge of your own health. It's not me. And so I don't take responsibility for when things go wrong either very much, because most of the time the things that go wrong are actually due to lifestyle changes. So that's really the main philosophy, is that patients themselves are in charge of their own health, and figuring out how do we give them the tools to be able to make the changes that they want to make is kind of an important thing.
Well, you've also, I remember, so Dr. Dave not only was my high school classmate, he used to be my doctor. Okay, so this was back in around, we were in a small group Bible study, together starting around in 1995 or so. And then he was my family doctor as part of, the Austin Clinic became part of Mayo Clinic Health System, and he was my doctor. And I remember him talking about metabolic syndrome back then.
Yeah.
And how long do you think it's been that you've been interested in that, Dave, and why?
Well, metabolic syndrome is a syndrome because it's a collection of things that you notice about patients. So a disease is something that you know exactly how it works. A syndrome is, well, this goes along with that, and that goes along with that, and you notice these things walk together, and so you think, gee, this is a syndrome. And that first got started as a discussion probably in the late 90s, maybe the early 2000s. I don't remember exactly, but it was at that time I had begun to notice that there were these things that seemed to walk together, that people would have a high triglyceride level and their blood sugar wouldn't be that good, and they'd be kind of too big in the middle, and their blood sugar would be kind of high, their blood pressure was kind of high, things like that. And, I would see that these went together, but it wasn't until I got a publication, it was from the National Cholesterol Education Program back in those days, that they mentioned this thing called metabolic syndrome. And I'd never heard of it before, but they put all these things together. And I said, oh my goodness, that's it. And this is a single entity. And so I started looking at it that way. And as a result, I started realizing there's a central mechanism for all this stuff. Quite a long time ago, probably in late 1990s, I attended a free medical conference teaching me how to prescribe intensive insulin therapy with insulin pumps for people with diabetes. And the calculations that they gave me in that conference, was a 4-hour conference in Des Moines, Iowa. Basically, those calculations, the mathematics that they taught me, solidified all of it. It was like, this is due to insulin resistance. I know exactly what to do to manage this problem now, and I actually have the calculations to do it. And so that just kind of codified it. So then I started really treating the whole thing as a single entity, and I've just been building that model ever since, just figuring out how do you make this work. And it's largely around lifestyle change. It's not something that you treat with medicines, although medicines can treat all the different parts.
So do you want to share what some of those lifestyle changes would be for your patients?
The key central mediator of the metabolic syndrome is resistance to insulin. Insulin's a hormone that your pancreas makes in cells called the beta cells. And that hormone's job is to ask your cells, do you need any fuel or not? So the fuel is glucose, blood sugar. That's in the blood, of course. But fuels are funny things. You need them, otherwise your motor doesn't run. The problem is if you get too much of it, your motor doesn't run either. So it's like you got to put gas in your lawnmower, but if you put too much gas in your lawnmower, you don't control it, it doesn't work. And cells are the same way. So they can't store very much glucose in them. So they're always having to let some in, but then they're burning it off, and so then they need more. But they don't need more until they need more. So you've got a system inside the cell that basically shovels glucose into the motor and runs it, but then that fuel bucket gets a little bit low and needs to be replenished. So there's a system then of the guy shoveling the fuel into the motor, and he has a communication going on with a guy who is standing by a fuel door on the cell membrane. And that guy's job is to listen for when there's a fuel shipment. And so the fuel shows up on the loading dock outside in the blood, and insulin knocks on the door and says, I got milk for sale. Do you need any for your refrigerator? Or I got fuel for sale. Do you need anything for your motor? And so the insulin is the door-to-door salesman. He doesn't know whether that cell needs it or not, but he's knocking. And so then the guy on the other side hears the knock and asks the guy monitoring the fuel bucket, how much fuel are we doing? Do you need any more? And that guy might say, yeah, we could use a little more. So then the guy at the door opens up the loading dock door, fuel comes in, and he closes the door, and insulin goes and tries to sell some more to another cell. And in type 1 diabetes, what happens is you got a load of fuel on the fuel dock door, but you don't have anybody knocking because the pancreas isn't making any insulin at all, basically. So that the pancreas has been killed off. In type 2 diabetes, which is by far the vast majority of diabetes, it's at least 95%. That kind, basically what's happened is over time, the guy that answers the door has gotten more and more and more deaf. And the cause of that deafness is over intake of carbohydrates. And carbohydrates are either short, those are called sugars, or they're long, which is chains of sugars, those are called starches. As far as your body's concerned, there's no difference. So if you eat a carbohydrate, sugars or starches, your blood has to manage that, and the insulin's job is to do that. If you overdo it, you begin to wear this system out. Where that problem becomes not controllable varies from person to person. And so some people will get diabetes, type 2 diabetes, earlier than others. That just means they've gotten a deaf enough doorkeeper earlier because they can't tolerate as much of the sugar. So that's the key, is controlling the carbohydrate intake in the diet is the key for the entire metabolic syndrome because it affects all of it, not just the blood sugar part, but also the blood pressure, the high triglycerides, the low HDL cholesterol, and the storage of excess fat.
I think what we're seeing here, I think, Dan, what you've just seen is Dave's heart. Dave's heart as a teacher, and that he really loves to explain things, and he has a real gift for doing it with analogies that help people really understand what's going on. I think you also see that that's something that doesn't happen very easily in a 15-minute visit, in a 15-minute primary care visit. And so, Dave, I think maybe you could talk a little bit about some of the frustration that caused for you working in the insurance-based healthcare system that led you to eventually leave the Mayo Clinic Health System and go to some other places.
Right. So in an insurance-based system, you're reimbursed based on what are called relative value units. And big, long visits have higher relative value units. However, you can't do as many of those. And so then people that do really short little visits don't generate as much of a relative value unit for that visit, but then they can see a lot more patients. So their pile of relative value units, or RVUs, by the end of the year is a lot bigger. And you get paid based on how many RVUs you generate. So people that want to spend a good long amount of time and spend time with patients basically are financially punished for doing so. Because at the end of the year, those folks don't have as much money seeing these patients. And that's an intentional bias in that payment model because you want to build up the clinic's RVU basis too, because that's how they make money. So then they incentivize clinicians to have short visits that generate lots of RVUs by the end of the year. But the problem is that if you're going to do a lifestyle change, there's not enough time to address that in short visits. So if you have a 1-hour visit, you can address more things, but you will address way more than if you do 4 15-minute visits, or in my perception, 25 15-minute visits. So I just don't think that model of short visits ever works for discussing complex lifestyle change. It just doesn't work. So people say, well, it's hard to practice family medicine with 15-minute visits. And I basically, my contention is no, it's not possible. It's not at all hard. It's impossible. So that model is what became more and more frustrating, and on a personal level, my income, when I was working for Mayo Clinic Health System in Austin, my income decreased because of that every single year for the final 7 years that I was there. So when inflation is going up and everybody else is making more money, my income went down every single year for 7 years in a row. Well, finally, you have to basically decide how you're going to do this. And so I finally had to bug out. Now, I didn't just quit. I went someplace that had kind of a different payment model that taught me in a very short period of time a different way of financing medicine. And that's a kind of a different story, but that was part of developing who I am now and the new payment model that HELPcare runs.
So what were some of those stops along the way? You went to a place in the Twin Cities. While you still maintained your home here in Austin.
Yeah.
But
My wife said she was never going to leave, so she stayed here.
She got you back to Austin and she wasn't going.
Yeah, exactly. I should mention that she was the one that said we were moving to Austin in the first place back in 1992. And I said, there is no way I'm moving back to my hometown. And she said, well, thanks for your opinion, but she made it happen anyway. So like, okay. Anyway, I left Mayo Clinic Health System and worked for geriatric service up in the Twin Cities. That name no longer exists, but it still is an existent company. And they hired me to operate a kind of an experimental inpatient geriatric unit in the hospital. And the reason for that is when geriatric patients are in the hospital, they're treated very algorithmically. You know, the thing that brought them into the hospital, the acute disease, usually gets taken care of pretty well, but they leave with about 7 new things wrong because they were in the hospital and they were treated that way. So they wanted to develop a different system, which is called a collaborative acute care for the elderly unit or case unit. And so that was what we were doing, and it was very, very successful, but it didn't work out for a number of reasons. And so that position ended after probably only about 4.5 months or so. But in the context of that, I learned a different way of financing medicine, and that was contracting with the insurance companies and doing shared risk. So the clinic would say, well, we need you to pay us more, but we're going to take on some of the risk if things don't turn out the way you want them to turn out, which is low cost. And so what they were doing is slowing down the process of medical care while managing these cases better so that the costs weren't higher. And just an example, the case unit that I was working in, it's very typical that patients with heart failure, diabetes, or pneumonia, or various different things, there's a good chance that they're going to be readmitted to the hospital with the same problem within just a few weeks, because there's not a transition process in management. Our readmission rate at the case unit was 3%, which is considered phenomenal. That is a miraculously low readmission rate. I mean, you feel like the quality guys are really, they lose their hat if you get it down to 20%. You know, getting it down to 3%, they just say, well, that's not possible. And yet that model actually worked. So that whole idea of there's a different way you can get paid to do this by sharing the risk and having people that really know what they're doing actually run the process rather than insurance companies saying, well, we know what quality is. They don't know what quality is. They know what low cost is. So then after that, I spent a little time doing some locum tenens stuff, which is just working in ERs and acute care centers and stuff. But that's not really my heart. I really want, primary care and long-term relationships and things like that. So I took a position way up by Mille Lacs Lake. My wife's still living in Minnesota, in Austin, 4 hours away. And I worked in that position, just a regular primary care system, for about 4.5 years. And during that time, I'm marinating on all this stuff about how do you get a different system that is paid differently. And one of my colleagues, a friend of mine, contacted me one time and said, you should take a look at this clinic that I've done he was doing locum tenens stuff too. And he said, I've done some work with these guys, and this clinic has the model that I think is right for you. And I didn't take him up on that right away, but later on, living 4 hours away from home and getting home 2 times a month and long driving and all that, it was really starting to wear me down. So I gave a call to this place, and it was with the Pipe Trades Services Minnesota, and that's a company that manages the benefits for the different pipe trades unions, so plumbers and pipe fitters and sprinkler fitters and steam fitters, that kind of thing. And so they managed that system, and they decided that they were going to build their own clinics and hire their own doctors and practitioners and basically pay for it. And so it was a limited population that they served, but it was based upon, we're not going to make you see a certain number of patients a day or build up RVUs or any of that kind of stuff. So it was a different payment model. And so I left my position at Mille Health System and joined the Pipe Trade Services Minnesota Family Health and Wellness Centers, one of the worst named clinics I've ever worked for. But, the idea was it was a good model with a bad name. It was just too long. But anyway, that was a brilliant idea. And that's when Lee and I had our discussion about, gosh, I got to tell you about this place. And that's kind of where the egg that cracked open and became HELPcare eventually came about.
Yeah, I think that's a great place to break, because there was a fateful coffee that Dr. Dave and I had on October 12th of 2019 that kind of blew my mind up at the same time, because he was telling me about this clinic where he's working, and it started a thought process going with me. And I think next time when we get together, we can talk about what happened then and what that discussion was like, and what happened in the few years just after that, before we launched the first HELPcare clinic in Austin, Minnesota in February of 2022. So that's the plan. We'll look forward to seeing you all in the next session and talking further about this. But Dan, thanks for joining with us, and
my
Dr.
pleasure.
Dave, it's been great knowing you all these 50 years or so, but especially over the last few years, getting to work directly with you. And I'll just say, I'm seeing you make a difference in people's lives. It's really the time that you get to spend with them, and the fact that we have this clinic here where you have other practitioners who are like-minded and practicing in a similar way is really making a difference for the members of the clinic.
Thank you, Dr. Dave. Appreciate you.
Thanks for joining us. If you enjoyed this episode, be sure to leave a comment or a review, and to subscribe on Spotify, Apple Podcasts, or on YouTube. And also to share Take Charge with HELPcare with your friends and on your social media channels. At HELPcare, our passion is helping people take charge of their health and their health care, helping employers take charge of their health plan expenses, and helping physicians and other practitioners take charge of their healthcare careers. Learn more about the HELPcare Clinic difference at helpcare.health.